ACR Journals on Air podcast. I'm your host, Vicky Shanahan. We live in a world filled with data. As physicians, we're constantly inputting data into electronic health records. But is that data usable in real-world settings to inform not only our healthcare systems, but also improve care for our patients? In a world swimming with data, what does real-world evidence really look like? The manuscript we'll discuss today is Inferring Rheumatoid Arthritis Disease Activity Status from Electronic Health Records Across Health Systems. It was published in Arthritis and Rheumatology, and a link to the manuscript and disclosures is available in today's show notes. It's a real honor to be joined today by the senior author of this manuscript, Dr. Kat Liao. Dr. Liao is a clinical investigator, practicing rheumatologist, and associate professor of medicine and bioinformatics at Harvard Medical School and the Brigham and Women's Hospital. She built her career studying both the long-term outcomes of rheumatoid arthritis and developing bioinformatics methods to leverage big data for clinical and translational research. Dr. Liao's research focuses on applying methods such as natural language processing to electronic medical record data to perform clinical studies in RA and other conditions. Through her work on the informatics for integrating biology and the bedside, I2B2 project, Liao led the team to develop an EMR research platform for RA studies. This platform integrates clinical and biomarker data with traditional genetic association studies and new approaches to data analysis, such as the Phenome-Wide Association Study, or PHEWAS. Dr. Liao was also extending this study to study long-term outcomes in rheumatic diseases, including, in particular, major cardiac events, or MACEs. Welcome to the show, Kat.
Thank you. It's my pleasure to be here.
So I wonder whether we could jump right into the background of why you did this analysis. Our electronic health records are full of data, and rheumatologists have treat to target drummed into them from the first day of fellowship. You're showing, however, that generating real-world data from electronic health records is not quite as easy as it sounds. Why is that?
Yeah, sure. I'm happy to dive into this just a little bit. So maybe I'll start with this concept that, as you all know, in clinic, we struggle a lot with the data. That can tell us which drug would work better for which patient at what time. So in this study, we focus on rheumatoid arthritis. And so maybe I'll set the backdrop here. We all know that clinical trials are the gold standard in comparing treatment effects for, any particular disease, for example, in RA, treatment A versus treatment B. However, they're not really designed for practical purposes to reach the level of detail we need in the clinic. So that is like what type of RA patient might do better with one drug versus another. So electronic medical record data is a type of real world data that has large populations that may allow us to do this, but the data are really messy. So for example, if you were to randomly select 100 patients with at least one RA ICD code or diagnosis code, and you do the chart review, only about 20 will actually have a code for RA. So what this identifies that even identifying the patients that you're interested in can be difficult in messy electronic medical record data. Now, in this study, what we're trying to tackle is disease activity. And the reason for that is because clinical trials, the main outcome is treatment response, which is defined by disease activity. And so in order to then do a study comparing treatments using real world electronic health record data, you will actually need the outcome of disease activity. And that is a complex outcome that is not collected in a standardized way in the EHR. I think we all know that. There are a few institutions or a subset of physicians who do their DAS28 or their CDI, which are disease activity measures that are calculated as a score. But the rest of us are saying all this in the notes. So without this key outcome in a standardized manner that you can pull out for a research study, it's very difficult to leverage this large real-world data set to generate real-world evidence on treatment effects. And so that's the goal of this study. We set out to use the latest technologies we had available to us with the electronic health record data to infer disease activity using machine learning.
Oh, that's great background. The field of AI is growing exponentially, but even AI is not so great at mining electronic health records. A few other investigators have tried something like this before. Tell us a little bit about those background studies and what those studies have shown.
Yeah, definitely happy to. So maybe I'll start with saying there are many types of AI, and machine learning is one of them. And so to date, most of the published data we have in inferring disease activity from large databases is using machine learning. So the take-home message from many of the studies, or actually there are few well-designed studies that I wish I can go through all of them in detail, but I think the take-home message is that applying machine learning to administrative data or structured EHR data, such as diagnosis codes and labs, to infer disease activity could not reach a model, or say the models are limited in performance to the point where the investigators concluded that they would not necessarily use this as a model for disease activity for future studies. Another take-home point from these studies is that, when a model doesn't do well, you think about, well, is it the data? There's always this, saying that everybody uses: garbage in, garbage out. But it's not always just garbage in and garbage out. It could also be: are the data complete enough? Are we missing the key data points that you need to model an outcome such as disease activity? And so I'm sure the clinicians who are listening are saying, of course, disease activity is not coded. A lot of the information on disease activity, for example, swollen and tender joints, the presence of synovitis, are actually in the notes. So the challenge here then is getting the data out of the notes, deciding which data to extract, and the best way to extract these data at scale for thousands of patients, then integrating into an algorithm for disease activity that you can then use to study treatment effect. So AI, I just want to emphasize here, is artificial intelligence. You could tell it to go in there, even the LLMs, but it doesn't necessarily know for specialized things for now, because the training sets, even for the LLMs, the large language models, are general data sets, what to look for when you're looking for disease activity.
Yeah, I mean, that's a really interesting point. And obviously, different physicians document in different ways, different health record systems force us to document in different ways. So, in this study, you examined two different health systems for your analysis: the Brigham and Women's Rheumatoid Arthritis Sequential Study, or BRAS, and the Veterans Affairs Rheumatoid Arthritis Registry, or VARA, along with their corresponding electronic health record systems. Tell us about those two populations and why you chose them.
Yeah. So when you think about training, so the goal of this study is to develop an algorithm using electronic health record data to infer disease activity. Whenever you train an algorithm, you need a gold standard, a robust gold standard. And in these two cohorts, disease activity is collected in a very robust way that is reproducible. So, for example, I can tell you in the Brigham Rheumatoid Arthritis Sequential Study, known as BRAS, the joint counts are taken at each visit, and all the components of the DAS28 collected at regular intervals. This is similarly done in VARA, the VARA cohort. So now you have cohorts of anywhere from 13 to 1,500 patients with rheumatoid arthritis with disease activity collected as a score in a standardized manner that you can use, are used in a research study, that you can train an algorithm on these thousands of patients to then apply this algorithm to the 20,000 patients with RA in the EHR in VA, or actually there's more than 20,000 in the VA. That's the number in the Mass General Brigham, and more even a higher number at the VA. So the key thing to this is that they're linked. The VARA and BRAS are linked with their electronic health records. So then you're able to take the VARA patients, take the gold standard, for example, of DAS28, pull out the corresponding electronic health records and determine which of the data best model disease activity in each institution. The other key reason why we were very interested in these two populations is that when you're designing algorithm, we're always interested in making sure, or testing, whether it's transportable and the generalizability. So this was a very good way to understand two extremes. At the Brigham and Women's, we have a more typical RA cohort in the sense that it's 80% female with RA, though it is a tertiary care center. Vera and the VA EHR system is a very different system, predominantly male RA patients in a very different healthcare system, where all the majority of the veterans are covered for their treatments. And so this is a really good way to stress test an algorithm with different populations.
And the VARA registry is from VA sites all around the country, right?
Yes. So it's a nationwide cohort.
Great. So it gives you kind of how different physicians in different practice settings are recording data in their electronic health records.
Yes. So you have even more variation in the VA system and the VERA registry than in the Brigham system.
Yeah. So walk us through the study design. There is a diagram in figure 1. Could you describe it for our listeners and explain why you designed the study this way?
Yeah. So we talked about the populations a little earlier. They're different populations. They have rich data on disease activity. They're linked with their EHR. So you can see that in figure 1, panel A, where you have each of the EHRs. We phenotyped RA in each of those cohorts using the algorithm I mentioned earlier, an RA algorithm using codified data and natural language processing. And so the goal is to first step is within Vera, or the patients who are in Vera, pull their EHR data, and you have the structured data, you have the unstructured data, which are the data that we're pulling out of notes, and training it on the gold standard disease activity that's already present in Vera. So that's the only Vera data we're using. It's the same idea with BRASS. And so what you see in panel B is that we first did the training within the institution. So we took in Vera and in BRASS. So I'm going to just start with Vera. You have, over 1,500 individuals with RA with disease activity over time. And we broke the data set up into a training and validation set. Because what you always want to do is you train an algorithm. You don't want to there's this concept of overfitting. You don't want to create an algorithm that you can create a wonderful algorithm that's directly just fitted to those data. But what the goal of this is not just obviously Vera doesn't need an algorithm for disease activity because they have the disease activity. The goal is to create an algorithm that you can then apply to the 70,000 RA patients in the VA so that you can infer their disease activity to do these larger studies. An important point I probably should have brought up earlier is I keep mentioning Vera and BRASS have these data, and they have anywhere from 13 to 1,500 patients. But when we're talking about these, the studies that we're trying to design or trying to use these disease activity measures for this inferred disease activity, we're actually trying to study larger populations. So if you think about 1,500 patients with RA and you're trying to compare, let's say, 2 different drugs using certain inclusion criteria, you start to get to very small numbers. So the goal is to get as large a population as possible with disease activity so that you can get down at these subgroups of patients to understand what treatment might work better for which patient comparing which drugs. So I digress a little bit there. So I'm going to go back to this training and validation. So the first thing is we trained within institutions. We wanted to see if we were able to create a robust model within the institution. But the next thing is you always want to know, or we would like to know, I think it's more useful if you can create an algorithm that can be ported across institutions. And so what we did there is we trained an algorithm in Vera and then validated using BRASS data, meaning then you applied it to the BRASS data, see how it did. And vice versa. We trained an algorithm with BRASS data and then ran it on the Vera data to see how it performed. And so that really is this gives you the structure of the study.
Yeah, no, that's helpful. And are you able to share a little bit more about the data extraction from the electronic health records? Can you tell us about the knowledge network model you used and how really did you apply natural language processing to gather the information from the records? You talk in the manuscript about concept unique identifiers. Can you tell us how you kind of codified, structured these narrative features that are in the EHR?
Yeah. So when you think about data, any type of data, but EHR data, there are 2 main types of data. There's structured data, and that's data that's hard-coded, like the diagnosis code, the laboratory codes that are often, stored in databases that are relatively easy to search for. Then you have the unstructured data. That's all the data that, as it sounds like, unstructured. It's the data that are in the notes that are typed either any which way. It could also involve reports that have some structure, but they're not searchable in a way where you can say, okay, give me disease activity, or give me the bone mineral density for in all these reports of all different shapes and sizes. So that's the unstructured data. What you're pointing to, what this question is getting at, is it really is a challenge to figure out, well, which are the data? There's millions of data points in the EHR, even potentially more, depending on how much you can mine. Which are the ones that you should consider for an algorithm? Because even for a machine learning algorithm, the threat of overfitting is a possibility. You can throw lots of data at it. You can either overfit it, or you just throw in too much noisy data that gives you a really not so good model. The knowledge network we used is something that we developed prior to this study. One of the, even as someone who's been working in this field, I think, and a clinician, we don't always know what data are on the other side. What's on the back end? What's available to us when we're interested in studying a phenotype or an outcome? And so what we developed was a knowledge network using methods that allow us to understand the relationship of, let's say, all the codes to each other, and all the codes and NLP concepts to each other. So I'll start with the codes, and then I'll talk about NLP concepts. So I think the easiest way to think about this is to think of extracting all the data on all the patients, on all the structured data, the codes, the labs, the electronic prescriptions, and creating a giant matrix of how they're all related to each other. Once you do that, you're able to also create what you call vectors that understand the relationship and the degree of the relationship between each of these, what we call entities. So for example, you would expect that there's a really strong vector for a rheumatoid arthritis code and methotrexate, and that you may have a similar vector for, let's say, lupus and Plaquenil. So it's these types of methods that are now available to us that allow us to take large amounts of data, understand the relationships between them, quantify the relationship, so that now I could type in. So we created this knowledge network and a graphical user interface where you can type in rheumatoid arthritis, and all the codes that are associated with rheumatoid arthritis would pop up. And this is based on data. It's data driven in the electronic medical records. And so we created a knowledge network both using VA data and Mass General Brigham data. So Mass General Brigham is the EHR of Brigham and Women's Hospital. It's a little trickier with natural language processing. So natural language processing is applied to the unstructured notes. Concept unique identifiers are a number for unique medical concepts. And we're lucky that the NIH and the Unified Medical Language System exists, because it is a resource that provides a listing, or not just a listing, defines a medical concept and all the synonyms related to a medical concept. Mm-hmm. So I'll give you an example. Atrial fibrillation is one way to say atrial fibrillation, this concept of atrial fibrillation, this irregular heartbeat. Another term that I don't use as much, but it perhaps is used in other settings, is auricular fibrillation. But it's all the same concept, that same idea. So identifying these concepts is important, and identifying unique concepts is important. So what a concept unique identifier is, it's relating an actual ID number to a specific concept. Why is that important? When you run natural language processing on notes, there are many different ways to say a similar concept. So I gave you the example of atrial fibrillation, auricular fibrillation. Maybe the other one I could have used is statins. There's many ways to say statin, say simvastatin, lovastatin, fluvastatin. But really, at the end of the day, as an investigator, what you need to know is how to roll it up into one drug group. And that is what a concept unique identifier does. It gives you these parent concepts, and you can break it down into child concepts for studies.
Yeah, that's really, really helpful. Thank you for explaining that. It's making me think that you're essentially training your algorithms to really be the human rheumatologist in the room of understanding uh, what are the ways that we write our notes and what does that really mean? How do you kind of infer that from the record? Um, I want to take you now to figure two. And this is really describing how you inferred disease activity from the data elements that you extracted. Can you guide us through the process that you use there?
Yeah, yeah. And so one of the things that is maybe not unique, but one of the important aspects of this algorithm in general. So I'm taking a step back and saying, well, why is this so hard to infer disease activity? So we talked about one, the data are not necessarily coded. We have to pull it out of the notes. People can say it any which way, Vicky, as you mentioned, with different physicians, different practices, and trying to figure out how to apply an algorithm that can take these very messy data to infer disease activity. Now, the other issue is we need temporality. We can't just say, okay, this one patient in their entire history, tell me their disease activity, pulling their data, because then you're just pulling all their data from all time and giving them a global disease activity. Uh, for these types of studies, what we're trying to do is understanding a disease activity at a specific time point, time zero, where you might be comparing treatments, right? So treatment A versus treatment B at time zero. 1 year later, treatment A versus treatment B for the population at T1. So, mirroring that, we had to think of a way to infer disease activity at specific time points. And this actually turns out, for the training purposes, we had to do that. Imagine in registry visits, you have different visits and they're at different intervals. And at each interval, so for a given registry, whether it's VER or BRASS, you have a disease activity at one time point. But that one note does not necessarily give you all the information you need for disease activity. For example, even for those of us who are calculating DAS28-CRP, sometimes you have to wait a month, sometimes two, for the patient to get
Yeah.
CRP so that you can calculate the DAS28-CRP. And so what we're doing here is just showing you how we're doing this modeling. We're pulling out, so for each registry visit, we're pulling out EHR features plus or minus 3 months. So we're extracting the codified and any NLP data within that period to then determine the probability of moderate or high disease activity at any given time point.
Yeah, so this is messier than it sounds up front, I think is the take home from that.
Yes, very messy.
And requires a little bit more thought. You used something that stood out to me in the manuscript, a ensemble machine learning model called Superlearner, which sounds like something I wish I'd had in medical school. What is it, and how does it work, and why did you pick it?
Yeah, that's a good question. So first of all, I want to acknowledge that the two co-first authors on this paper are biostatisticians. So it is a not a I'd say it's a very technical reason. Well, actually, maybe I'm going to start over with this one. So I'm going to start by saying that the two co-first authors on this paper, David Cheng and Sean Wang, as well as my co-senior author, are biostatisticians. This is a very technical paper. So I'm only going to give you the high level here. When we think about what model to use, you're often thinking about what is the question, what is the goal that you're trying to achieve here, and also need to understand the data. Whenever we go to think about which machine learning model to use, we're thinking about those questions and what you're looking for. So why? So for example, the goal of this study is not to create a model that only works for one institution and works really well just for that data, right? That is possible. What we're trying to do is create an algorithm that can potentially work across institutions and even within your institution across time, so it's generalizable. We tried different machine learning models, such as random forests and others, and that all did quite well, actually. Superlearner is a type of model called an ensemble machine learning model, which means it can take some of the strengths. So all the different models have different strengths and limitations. The strengths that are particularly good for our study. And so it turns out we tested Superlearner, this ensemble model that takes certain strengths of different machine learning models across different models, and found that it performed the best in terms of model performance within the institution and model performance across the institution.
Okay. And so explain to us, if you can, how do you train and then validate the model? And how do you assess the relative importance of different features in the algorithm?
Yeah, so training the model is, as I showed in figure 1, we do training and validation. So when you're taking, and what we mean by that is the gold standard label that you're training against, the DAS28 CRP, whether it's infer or brass, you don't want to use all of it at once. You want to take a piece of it for training, train your model, and then once you have the best performing model that you want to use, take it and make sure that it is, even within your institution, this is like internal validity, that it runs well. And that's internal validation. The external validation is then when you take the model at one institution and then you validate it at another. How did we actually, what are some of the metrics we use? And that's highlighted in table 2, where we're looking at the discrimination. How good is it at saying whether you have moderate or high disease activity versus remission low? And that's one of the many metrics we use to assess the models within and across the institutions. I'll mention here that the model, we could create a pretty good model within the institution, but turns out it's not easily transportable. Now, how did we assess the relative importance of different features in the algorithm? We use different methods, but there is in the supplementary a graph of SHAP scores. So this is a method that's developed precisely for this, for machine learning models, which use a lot of different features to understand the relative importance of the features in the model. To assess the relative importance of the different features in the model, we use the SHAP scores, which kind of lines up, it kind of ranks the most important features to the least important features. Now, actually figuring out what are the important features, that's what the machine learning algorithms are doing. We're giving them a couple hundred features or variables, right? Codified data extracted using NLP. We're giving them the gold standard, which is the DAS28 CRP from our registries. But this is where the artificial intelligence comes in. As humans, with hundreds of features and thousands of patients, we can't, and with the model, with the methods we had before, there's not a good way to all together, all at once, figure out which features are most important for DAS28. This is where machine learning has a lot of power. And I think how many of us have been taking advantage of this ability to develop these algorithms using more features.
Yeah, it's interesting because you're kind of really converting all of this clinical data that we as rheumatologists use during our clinical visits and turning it into essentially math, right? To allow the computer to understand it in a way that it can then be used to model likely trajectory of different treatment variables, right?
Yeah. So Vicky, that's like such an important point. What these machine learning and AI needs is basically ones and zeros. So what we're trying to do here is take all these data from all the rheumatologists and turning it into numbers and vectors that AI can use to develop the algorithms.
Yeah, and I'm kind of fascinated by that because many of us chose to go into medicine because we were good at math, but it wasn't our passion. And at the end of the day, the world is being converted to math, right?
Can I tell you, I went into this for the opposite reason. I did not want to do math. I went into medicine. Now I'm stuck doing more math than I ever wanted to do.
Right. I kind of love that the world can be explained by math.
Yeah, it's amazing.
So I love your paper because you then take this like very dense computational analysis, and then you apply it. And you applied this inferred disease activity tool into a study of patients with rheumatoid arthritis to look at the relationship with major adverse cardiovascular events, your passion. Tell us, what did you do in that particular analysis? So that I think is parts tables 1 and 2. What study populations did you use for that portion of the analysis, and how did you do it?
Okay, so maybe I'll start with the reason why we did this. So, as you said, Vicky, we did this complicated analysis to come up with this algorithm for disease activity. But does it work? So we think about validity. Does it worked? We did some internal validation, checking within the cohorts at the VA and the Brigham in terms of did it validate in Vera and BRAS. But the second thing is, would it validate for a different kind of question? We all know that inflammation and disease activity is associated with a higher risk of major adverse cardiac events, or MACE, otherwise known as MACE. And so our question here was, is our algorithm good enough? Would it be able to see that same association that others have seen over time using more traditional methods, directly collected disease activity? And so what we did is we took the RA cohort. So if we go to, if you're looking at the paper, if you go to figure 1, in panel A, you'll see a circle, a light green circle around Vera and BRAS. And that's the larger RA population. So we developed the algorithm, then we applied the inferred disease activity to this larger population. And now what we're studying is MACE in this larger population. In this case, we are using an outcome of MACE defined with administrative data, which includes MI, stroke, and looking and testing the association between disease activity at a certain time point, which is very important because what you're trying to replicate is this idea that higher disease activity is associated with future major adverse cardiovascular events. And so in panel 4, what you can see is that algorithms were able to recapitulate this known association where individuals with moderate to high DAS28 at a particular time point are at higher risk of future major adverse cardiovascular events. So while this wasn't earth-shattering, this helped us, I hope others, but definitely us, to believe that we are indeed capturing disease activity in a way that's relevant to the registries, that fits well, validated in the registries, but also for a different type of outcome.
Yeah, no, I mean, I love a little pragmatic hypothesis testing, and it's a lovely paper in that you kind of both combine the development of the model and then the use of the model in a really clever way. So thank you for sharing that. I'm a little fascinated also by the fact that I think it's in figure 3, you show that the model trained at one institution was not quite as effective when you used it at the other. I'm kind of struggling to understand that, because don't the rheumatologists see patients at both institutions? So the way they write their chart notes and their narrative components should be kind of similar across both institutions. Why is it, do you think, that the models struggled?
Yeah. And so I think this was a good way to demonstrate. When we talk about algorithms, we always say in our papers, you must validate or check your algorithm at your own institution, because sometimes it's easy to predict and sometimes it's not. So in this particular study, as you brought up earlier, Vicky, the VA data is nationwide VA data. So just data from all over different settings. Whereas those trained at MGB are very focused on one. It's data from 2 large tertiary healthcare centers. So that in and of itself, and the patient population is different. So we weren't incredibly surprised, but there was this notion that, well, shouldn't all RA features be of similar importance? So it turns out there is a nuance to this. The features are So which features are important? So for example, you can imagine rheumatoid factor, anti-CCP, a mention of synovitis. Those were all important. It was how important each of them were in the different institutions. So how they were weighted. And that was really one of the major differences in the performance of one algorithm at one institution versus another. But there were also different capture. So this goes back to this difficulty of EHR. There's heterogeneity of what data are available at each institution. So some of the important features at VA were, not used very much at Mass General Brigham, and vice versa. So I think this just hammers home how important it is in this world of AI. This is artificial intelligence. It doesn't know whether it's working or not. It'll run on anything, it'll give you an answer, but it is up to us humans to figure out whether it is actually doing a good job on the data and giving us the data that we're looking for and need in a very robust and fair way.
Yeah, I mean, this really kind of drives it home that this field is evolving very fast. And as someone who's built your career in bioinformatics, machine learning specific to rheumatology, I'm wondering, how do you see this modeling of real world data evolving over the next few years? You know, the non-physicians seem to think this is going to happen quicker than you can order a Waymo. But I think anyone who's ever entered data into the electronic health records knows it's not quite as easy as you think. So Kat, what does your real world intelligence tell you that the future might hold for us?
Yeah, I think it's a promising time. I think that we are able to, we're generating certainly a lot of data, and we're able to now better extract that data. And as we talked about earlier, transform that real world data to real world evidence because we have more tools to do so. But I do move forward with caution. I think that the field is moving very quickly and perhaps quicker than we can process the information that's coming out, and that we need to take moments to slow down and evaluate what we're doing and make sure we're understanding what our goals are, and that all these tools and technologies are serving what our patients need and the goals for all these studies, which is to improve patient care. I worry a little bit that with the pace of the way things are going, with the way the tools are coming out, the applications without the validation, without the what we call human in the loop, we can run into some trouble. So I think I'm cautiously optimistic about the ability actually to answer a broader range of questions that we couldn't answer before with these tools and with these data.
Yeah, no, I mean, I share that, and I'm kind of watching from the sidelines, interested to see how this will all shake out. Our listeners always like to also hear a little bit about the human behind the analysis. And so I wondered, Kat, can you tell us your story? How did you come to be doing this work if you didn't really like math beforehand? And where did this machine learning passion come from? Is it something you developed in medical school, or something that really became an interest once you were in rheumatology practice?
Yeah, I know. I sometimes look back. I don't know how I ended up here. But I'll say, maybe I'll start off. When I was in medical school, we were still using paper charts, and there was no electronic health records for us to do machine learning on. Machine learning was certainly around, but it wasn't something that we were applying to healthcare. So I'd say I'd always had an interest in technology. I actually, before medical school, spent a year as an information technology consultant in the days of Y2K, when we were still using the government was still using mainframe computers, and we were switching over to newer systems. And so fast forward to how I got into machine learning, I was very fortunate during my fellowship training to be a part of the Informatics for Integrating Biology in the Bedside project, which is a big program project supported by the NIH, where Dr. Zach Kohani, who's now the chair of the Department of Biomedical Informatics, really had a vision that electronic health records were increasingly being adopted. We need to figure out a way how to leverage this for research. And it was in that setting. So I was, because of my interest in technology, I was like, okay, let's try this. I was so fortunate to work with individuals from that team. One of them is the co-senior author, Tianchi Kai, who is a biostatistician and bioinformatician, along with many others, to really figure out a way forward. How do you use this? I think we published from that, from I2B2, one of the first studies, or maybe I shouldn't say, one of the earlier studies using machine learning, using natural language processing just simply to phenotype RA, and showing that we could do this and we can do a better job, and that we could use these algorithms then to do a better job and improve power for genetic studies, for clinical association studies. And I think once from there, I've just been hooked, and that's what I've been doing as part of my research since, along with many of my collaborators from my I2B2 days.
Yeah, I love it. It's like the rheumatologist got adopted by the bioinformatics department, and that family has helped you thrive. I'm wondering, you've been successful both in generating a published body of work and then also very much securing funding for it. Do you have any tips for young physician scientists who might be aspiring to have a career similar to yours?
Yeah, that's a tough question I get all the time. Times have changed so much. It is hard to say, because I even think about, I recommend that my trainees, for example, if it's possible, seek out opportunities to get a master's in data science or a master's in in a computational field. Those masters weren't even available when I was coming through. So I would just say, talk to your mentors, talk to people in your field at your institution. How did they navigate the system to get to where they are, but also remain flexible? I think the way I got here was really um, kind of keeping my options open, seeking out new opportunities that I thought would be interesting, but also not seeking out every opportunity, but evaluating at each step, does this make sense for me? I'm interested. How do I incorporate this into what I'm interested in, which was RA and cardiovascular disease, keeping my foot in the clinical studies, but how do I pull these tools? So I think all along what I've been thinking is, these tools are really, they're new, they're exciting, they're powerful, but how do I use these tools to answer the questions I want to answer our clinical questions that are generated by my patients in clinic? How do I take these tools to improve patient care? And that's kind of been my guiding principle of what I use, what I go after, what I question, and what, where I'm going to spend all this time, digging away, as we talked about, at the data, and trying to wrangle it into a way that we can get clinical insights.
Yeah, that's a really good advice. As you've done this, I'm sure there've been ups and downs. I'm wondering, how have you managed the kind of unexpected twists and turns that come along with doing real world science? And are there any predictors of success that you're willing to share?
Oh, I wish I knew, Vicky. I think maybe you can tell me more than I can tell you. I think it really is just, well, okay, so maybe a couple of things. One is real world data, real world science is, you can't, it's not controlled, right? It's not like an experiment where I could control the environment. I come up with the clinical question, and you try to design the best study possible, and then you evaluate the data and you figure out what can you actually answer. So there's always unexpected twists and turns, always, something that comes up that makes you have to do the entire analysis that you worked on for the last 2 years over again. But it's having that backbone of methods. Despite all the new methods and tools available, you want to anchor yourself on robust clinical epidemiologic methods, and then on that kind of foundation, manage the twists and turns that come your way, and again, keep learning. And the other piece is keep learning, keep understanding what's happening around you. Build your research community of your collaborators, your trusted collaborators, and people that you can bounce ideas off of. I think that really has helped me to survive this general world of unexpected twists and turns of the research itself and the research environment.
Yeah, no, I mean, nobody operates in a vacuum, and neither do our patients. And I think like listening to you describe that is equally applicable to all of us trying to navigate a translational research career, and then our patients trying to navigate the healthcare system, and medication and alterations in one area will have impact across another. So I'll throw down the gauntlet to you to put some math around both of those problems. I want to thank you, Kat, for really sharing both your work and the real world experiences that shaped it. It's really been a pleasure chatting to you today.
Well, thank you so much for having me.
I'd like to close today also by expressing deep gratitude to our patients, physicians, and scientists who work tirelessly to ensure that real-world experiences yield real-world evidence in rheumatology. Every click, every data point tells a story and helps us see patterns that we couldn't recognize on our own. Thank you for turning lived experience into knowledge that moves our field forward. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRheum on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.